if you say, you know, if you move this bone on this bone, what motion did you just produce? Usually the answer to that question is not a posterior glide. The answer to the question is, what osteokinematic movement did you produce? Because if the question says, what glide did you produce, well then you answer it. But if it says, what motion did you produce if you move this bone on that bone, the question is asking you to name the osteokinematic movement. Okay? So, and in the AO joint, we really don't call a motion flexion or extension unless it happens bilaterally. So we're not going to call, you know, when you did that rotation, there were some of you saying, well, you produced flexion, or, you know, at this, on the right AO joint because it went this way or whatever. But that's not really true as far as the true osteokinematic movement, because craniovertebral flexion is both joints going there, and extension is both joints coming this way. So if only one joint is coming back, you don't name that the craniovertebral joint just flexed. You have to say, well, what happened on the other side? If the other side went that way, then that's right rotation. Okay? So that's where some of you were getting hung up, because you're saying, well, if I produced flexion at the right AO joint. Well, yeah, you did, but since you didn't produce flexion at the left AO joint, we're not going to name that as an osteokinematic flexion, because that motion is defined by both joints coming back. Okay? So you saw then how by moving C1, you can produce rotations that are different at the AO joint and the AA joint. Because if I move C1 to the left, I produced right rotation at the AO joint, I produced left rotation at the AA joint. And then when we made it to the left, we just flip it and we did the exact opposite. So that's what we're going to do with this patient. We side bent him to the left and we rotated him to the right. His pain was still there, so we said, okay, it has to be AO joint or AA joint. We're just not sure which one. So now what we're going to do is say, okay, go back to the right to where your pain comes on. And he says, okay, right there, I feel my headache. We're going to, you did this yesterday, we're going to go ahead and we're going to find C1. Remember, the transverse processes are right underneath of the ear. So we're going to grab a hold. Now Mike's neck is thick enough that there's no way both of my fingers, and my thumb will go to his transverse processes, but I use that grip anyway and just kind of squeeze. I can then hold him right here at the place in right rotation where his pain was produced. I'm going to take up the soft tissue slack by kind of moving it actually in the same direction that I want to go, and then I'm going to try to go ahead and rotate C1 to the left. So I'll have more pressure going on right here than I do over here, and I'm just turning C1 to the left. And I'm going to say to him, does that increase your pain? And see what he says.
No.
Okay, if he says no, it doesn't increase his pain, then what does that tell me?
AA.
Okay, I need you to stop
okay.
answering,
Okay.
because you already know this stuff. All right? So I don't want you to answer anymore.
Okay.
All right? It does implicate the AA joint because I just increased right rotation at the AO joint and it didn't hurt more. should hurt more. Okay? So to confirm that, he says, you know, I say to him, does that increase your pain? He goes, no, still the same. Okay, well, let's go the other way now. So what we're going to do is, he's still back at the, I'm going to now grab a hold with a little bit of a different grip so that I can facilitate left or right rotation of C1, and I'm going to try to push C1 transverse process on the left side now with my thumb, and ask him, does that increase his pain? And if it is the A joint, he should say, yeah. Now you could argue successfully that if this is acute, just the pressure of your hands may increase his pain. And you'd be right. So at that point, you don't know whether it's the AO joint or the AA joint. It's too acute for you to differentiate. The one thing you do know is it's not C2, C3. So you could go ahead and treat both the AO and AA joint for acute injury, which we'll go over. You could do modalities or whatever you want to do over both joints until it starts to come down a little bit, and then see if you can figure it out. But that's the way that you could try to bias the motion at the joint to see if you could get a better differential diagnosis of which joint it was that got injured. Okay, everybody good with that? So that's what I want you to try now, is just